All right, let's jump right in. Today, we're throwing on our scrubs and stepping into the emergency room to solve a pretty intense medical mystery. We've got a patient in serious distress. The symptoms are, well, they're confusing, and the clock is ticking. So let's get to it and crack the case of the epigastric pain. Okay, so the scene is set. A 42-year-old woman walks into the ER. And right away, every single word here is a clue for the doctors. Severe, steady epigastric pain, radiating to her back. This isn't just a simple stomachache. No way. This is the kind of description that puts the entire medical team on high alert. So this is where our investigation really kicks off. We have to figure out what's going on with our patient because, as you're about to see, her symptoms they don't quite add up. Something about this episode is different, and it's pointing to something way more serious than what she's experienced before. Okay, let's break down the clues. We've got the classic signs, right? Severe pain, nausea, vomiting. But here's the kicker, the part that really makes you go, she's had attacks like this before, but they were always over in an hour, maybe two. This time, it's been a full 24 hours and it's not letting up. And on top of that, there's this brand new, really alarming sign, scleral icterus. That's a fancy way of saying the whites of her eyes are turning yellow. Yeah, this is not her usual thing. Something is very, very different this time around. All right, so the patient has told her story. The team has listened. Now it's time to get some hard data. We're turning to the monitors. We're looking at the lab results. We're searching for objective clues. The body is always talking. We just need to learn how to translate what it's saying. And boom, here's our first piece of solid evidence from the vitals monitor. Her heart rate is 104 beats per minute. That's called tachycardia. It's a flashing red light, a clear signal that her body is under a ton of stress. The internal alarm bells are definitely ringing now. Now we're moving on to the blood work. And look at this. Her white blood cell count, that's her body's army, is at 16,500. That is way, way above normal. This is a huge red flag for a major infection or some serious inflammation. Her immune system is in an all-out war with something. Okay, this one is a big deal. Her total bilirubin is 9.2. To put that in perspective, normal is usually less than 1.2. This is crazy high, and it perfectly explains what her yellow eyes were trying to tell us. See, bilirubin is what's left over when old red blood cells break down. The liver is supposed to process it and send it out through the bile ducts. When you see a number this high, it's a massive clue that there's a major blockage somewhere in that plumbing system. And then we get this number, amylase. It's a digestive enzyme made mostly by the pancreas. A normal level should be under 140. Hers, a jaw-dropping 1249. This isn't just another clue, people. This is the smoking gun. It's pointing a giant flashing arrow directly at one specific organ, the pancreas. So let's take a step back. We've got the patient's story, we've got the physical signs, and now we have these incredibly dramatic lab results. It is time to connect the dots and officially solve this diagnosis. And this right here, this lays it all out perfectly. Her past episodes, they fit the profile for biliary colic. Basically, painful but temporary gallstone attacks. Annoying for sure, but they pass. But this episode? Oh no. The pain that won't quit and those sky-high amylase and bilirubin levels, that tells a completely different story. It points straight to acute pancreatitis. The whole game has changed. So there it is, the official diagnosis, acute pancreatitis. And what caused it? A gallstone, the very same thing that caused her previous milder attacks. But this time, that little stone has wandered off, gotten stuck, and created a major blockage in the common bile duct. That blockage is what jacked up her bilirubin, and most critically, it's what set her pancreas on fire. Mystery solved. Okay, so we figured out what happened to our patient. We solved the case. But what is pancreatitis really? Let's zoom out from this specific hospital bed for a minute and dig into the science of what's actually happening inside the body during an attack like this. Just look at this definition. It's an inflammatory process where the pancreas's own digestive enzymes get activated before they're supposed to, and they cause autodigestion. That is a clinical, almost polite term for something pretty horrifying. The pancreas literally starts to digest itself from the inside out. It's like a friendly fire incident on a catastrophic scale. Now, for our patient, a gallstone was the trigger, but as you can see from this chart, it's definitely not the only way to get pancreatitis. Actually, in the US, heavy alcohol use is the #1 cause. But look at the other culprits: certain drugs, super high triglyceride levels, even just physical trauma to the abdomen can set it off. Our patient's case, biliary tract disease from a gallstone, is the second most common cause out there. So the diagnosis is in, but we're not done yet, not by a long shot. The next critical step is to figure out just how bad this attack is. We need to assess the severity and then map out the best treatment plan to get our patient on the road to recovery.
To do that, doctors often use a tool like Ranson's criteria. Think of it like a severity scorecard. You look at a bunch of factors when the patient comes in: their age, their white blood cell count, glucose levels, and so on. A score of 3 or more means you're likely in for a rough ride. But look at our patient's chart. The only box she checks is that high white blood cell count. Her score is just 1. And that is fantastic news. It predicts she's going to have a much smoother, uncomplicated recovery.
So what's the game plan? It's actually pretty straightforward, and it's all about supportive care. Step 1 is crucial: pancreatic rest. That means nothing by mouth. You have to give the pancreas a break so it can heal. Step 2, pump in lots of IV fluids to keep her hydrated and her blood pressure stable. Step 3, manage that intense pain with strong analgesics. And then finally, once the pain and inflammation start to go down, you can slowly, carefully reintroduce food. A simple plan, but it is exactly what her body needs to heal itself. And that brings us to our final thought for today. Gallstones are incredibly common. I mean, up to 20% of people over 65 have them, and most of the time, they're just there. They don't cause any trouble, they're silent passengers. But as we saw so clearly in this case, all it takes is for one of those tiny stones to wander off and take a wrong turn, and it can transform a common, manageable issue into a life-threatening medical emergency. It's just a powerful reminder of how delicate and interconnected all the systems inside our bodies really are.